Just by way of background, so I'm an emergency physician, and I'm sort of a reluctant academic. I sort of got into this kicking and screaming, and what pulled me back in was actually the realization that the challenges that I was facing in emergency medicine in my practice, those challenges I was meeting by actually borrowing from my creative writing skills, and my creative writing skills were actually serving as clinical skills for taking care of my patients at the bedside. And that led to sort of more work on the role of creativity and creative thinking in medicine, and the fact that medicine, there's more dimensions more creative dimensions in medicine than we acknowledge, and that we actually have to prepare physicians to be more creative. So I'd written a couple of things on that, and when Ronan initially invited me out, I was initially asked to talk about sort of Doctors as Makers, this article that I had written. And then I was talking with Ronan, and he goes, everyone's talking about story. Why don't you try to link story? And so I decided to talk about a little idea that was mentioned in one of my pieces on this idea that we need more not knowing in medicine. And so I don't know how you feel about this, but don't throw fruit. And if you do, please keep it soft. So the writer Kurt Vonnegut famously gave this advice to writers: be a sadist. No matter how sweet and innocent your leading characters, make awful things happen to them in order that the reader may see what they're made of. If a long career in emergency medicine has taught me anything, it's this: real life can be a more ruthless writer of woe than anything conjured from the human imagination. And when awful things happen to patients, or when they perceive something awful is happening, they often find their way to the ER. And in this way, I learn a little about what they're made of, and how I respond to their problems reveals something about me. But this is when I'm most tested. When symptoms don't point to identifiable diseases, when the body hasn't read the same textbooks and journal articles as I have, when problems don't have names, when solutions aren't obvious, when stories are wild and unwieldy, when real concerns lay hidden in the landscapes of their experience. John Berger wrote this in A Fortunate Man: landscapes can be deceptive. Sometimes a landscape seems to be less a setting for the life of its inhabitants than a curtain behind which their struggles, achievements, and accidents take place. So just as Berger challenges our common understanding of landscapes, I'll ask that you consider a different mode of travel through them, and it begins with not knowing. So I borrowed this idea of not knowing from the writer Donald Barthelme's essay of the same name. He wrote, "Writing is a process of dealing with not knowing. That a writer, when he begins, is someone who doesn't know what to do. The artist must render all this messiness. Not knowing isn't an unfortunate and frustrating part of the creative process. Not knowing, in Barthelme's terms, is actually crucial to his art. In fact, the more serious the artist, the more problems he or she takes into account." So from the position of not knowing, we remain open when symptoms don't make sense and find comfort in that openness. It's resisting the urge to jump to conclusions and instead step back and frame problems correctly. It's being sensitive to what's missing in the landscape or what's hidden. It's paying close attention and being aware that there's a curtain exists and it deserves investigation. With not knowing, the focus moved from the manufacturing of answers to the curiosity and rigorous effort required to ask the right questions. Let's consider this case of Jill L. Jill L. is a well-dressed woman who comes to an inner-city ER in the middle of a Saturday night with vague symptoms that includes chest pain and shortness of breath. She's easily the best-dressed and best-smelling person in the entire ER. And she appears emotionally contained from the havoc going on around her. The young ER doc isn't that concerned for anything serious at first, but something doesn't sit right. And he returns several times to clarify her symptoms. He's left with little to latch onto except chest pain and shortness of breath. So that's where he goes. He chases a heart attack or maybe a blockage in an artery feeding oxygen to the heart. It's unlikely. She's young. She doesn't have any cardiac risk factors. What if it's a blood clot in the lung? She's grateful and doesn't mind staying the entire night for various workups. But when he doesn't turn up an explanation for her symptoms, she doesn't even appear distressed. The young ER doc is diligent, courteous, and entirely devoid of imagination. He analyzes and pursues her symptoms, but fails to engage with the landscape of her story. What the young ER doc doesn't ask is why. Why change the arc of her evening? Why interrupt plans that involve impeccable dress and come here? Why did these symptoms cause such distress? If he'd asked, she might have told him hours earlier, before all the testing, the real reason why she came to the ER. Domestic violence. She'd had enough. The doctor who felt rushed to find the answer rather than acknowledge the uncertainty in her story, who didn't bother to notice a curtain to peek behind, was a young me at the very beginning of my emergency medicine career. Not knowing is not the same as insufficient knowledge or poor application of knowledge. I should know the correct antibiotics for treating a hospital-acquired pneumonia. I better have a ruptured aortic aneurysm in the forefront of my mind when considering an older patient with a sudden onset of acute abdominal pain. Not knowing begins with a solid foundation of medical knowledge. Without that, it's difficult to parse out the gaps. Halfway through my internship year, when my white coat earned a fair share of wrinkles and coffee stains, and my gut didn't chill each time my pager went off, I experienced a moment of reckoning. I'd learned just enough to become aware of the immensity of all that I didn't know, producing an anxiety that haunts me to this day. So it sounds counterintuitive, but we need more not knowing because medicine has an uncertainty problem. The medical literature recognizes more and more the many ways uncertainty pervades core parts of clinical medicine, like diagnosis, prognosis, history-taking, and communication. When faced with uncertainty, the impulse of physicians is to reach for more data. But more data doesn't necessarily produce more certainty. We rarely reach the point where we don't have to interpret, where physicians don't have to take that leap into unsteady ground. Jerome Kesserer, former editor of the New England Journal, wrote this in 1989. He said, absolute certainty in diagnosis is unattainable, no matter how much information we gather, how many observations we make, and how many tests we perform. Besides, medicine doesn't suffer for lack of knowledge. Researchers do a remarkable job of generating knowledge, and one might argue that we might have too much of it. It's actually physically heavy. This is an article in the New England Journal published in the mid-70s where the author actually weighed the Index Medicus from the Index Medicus from 1879 to 1974. So thankfully, it's heavier in 1974 than 1879. But the author did go into great detail describing how in 1974, the pages were actually thinner and the margins were narrower. And I was thankful for that. So that was a confounding variable in his study. But a more recent article reported how there are 75 clinical trials and 11 systemic reviews published a day. Separating the signal from the noise is hard. And the mountains of information can appear so majestic that the limitations are not immediately obvious. Evidence-based medicine, the use of data gleaned from studying populations of patients, is only helpful once I've identified the problem for which the data applies. Medical knowledge often doesn't address the challenges of clinical practice. Knowledge alone doesn't help providers who are unprepared for the complexity, uncertainty, instability, and value conflicts that are often the source of real anxiety in medicine. Despite rapid advances in medical science and technology, in the US, it hasn't translated into higher quality patient care. Calls to redesign healthcare in the 21st century are well-intentioned, if not mildly disorganized. In addition to recommending systemic changes, more personal target areas have received attention, including establishing healing relationships, adapting to the needs, choices, and values of individual patients, and putting patients at the locus of control. Such patient-centered goals should be applauded, but often these bold declarations are fuzzy about methods for getting there. So how does one respond to a particular situation that is messy and without precedent? Patients are not always neat packages, and under the pressures of clinical practice, there's an urge to fold leaky problems into manageable parcels labeled with a diagnosis. By force-fitting an answer, physicians haven't eliminated the messy concerns. They've simply created a different story, one that they could control with an ending. Challenged by medically unexplained symptoms or patients' worry, physicians are inclined to respond with biomedical questions, offer biomedical explanations, or resort to pat reassurances, instead of confronting uncertainty and exploring the psychosocial or emotional elements in the patient's story. By dismissing the story, we risk committing a great moral harm, which is dismissing the storyteller. I recognize that developing comfort with uncertainty is hard, but it's supposed to be hard. But I still remember the beginning of my clinical clerkships. A more senior medical student pulled me aside and shared this bit of wisdom drawn from his year on the wards the year before. You can be wrong, but never in doubt. Now, fortunately, despite all the knowledge pouring into medicine, leading physicians are calling for more honesty with patients about the boundaries of knowledge, that we must normalize uncertainty and reset patients' expectations. Physicians who are themselves comfortable swimming in the waters of uncertainty are better able to participate in shared decision-making with their patients. So how do we cultivate physicians' comfort with uncertainty? How do we get their hands dirty with the idea of not knowing, recognize that despite scientific evidence, clinical guidelines, algorithms, and decision tools, medicine is at its heart a creative act? Well, we can learn a lot from the experts for whom uncertainty is their landscapes, artists. In practical terms, not knowing asks that we think like artists and attempt to process. By focusing on process, we gain insight into how our actions and beliefs are a reflection of the way we're thinking about the world. The art itself becomes a true account of the activity of the mind at work. Process receives less attention in medicine than outcomes. Outcome measurements are important, but I fear the emphasis on outcomes has diminished the value of other practices that are foundational to medicine, but harder to quantify. We need to develop a clearer mental map of our decisions, judgments, and biases. The cognitive psychology literature has revealed how experts across multiple fields, including physicians, are inappropriately confident in their judgments. Our excessive confidence in our beliefs is matched by what the social psychologist Daniel Kahneman said is the inability to acknowledge the full extent of our ignorance and the uncertainty of the world we live in. We like to believe we're savvy to what's going on in our minds, that our decisions are a linear string of conscious thoughts. However, often our impressions and beliefs appear in our minds out of the dark quiet. They're not the product of a rational process contrary to our beliefs. The best we can do is to become aware of the curtain that hides the landscape where our thoughts, judgments, and impressions take place. Not knowing recalibrates how physicians look at constraints. The practice of medicine is ripe with constraints. Whether it's not enough time with patients, spending too much time documenting or doing paperwork, the challenge of caring for sicker and sicker patients layered with socioeconomic problems, mental health issues, substance abuse, homelessness, violence, and poor food options. The biggest constraint might be the challenge of empowering patients to make better choices when they've never had the privilege of choice. Choice in their lives playing out as a decision between two bad outcomes. It might help physicians to look at constraints from the perspective of an artist who sees constraints as opportunities, a moment when you are forced to think about a problem from a radically different perspective. A writer once told me that it's important to write characters into corners, because then you have to write them out of there. That's when you begin to learn who they are, and how we respond to particular constraints reveals something about us, something about our personal style and individual voice as physicians. I recognized long ago that I'd rather suffer the consequences for being who I am, for being authentic to my physician voice, than being someone I thought I was expected to be. I can't talk about not knowing in process, working with constraints and getting dirty, working with uncertainty, without conceding that this requires taking risks and looking at failure differently, or at least recognizing that there might be various species of failure in medical practice, and some are acceptable and perhaps even necessary. But that's another talk. Before I go further, it might be a good time to ask whether I'm demanding too much, if I'm aiming wide of the mark, or if I'm just talking silly. There's no point in medical training where physicians or students are given a congratulatory slap on the back for not knowing. There aren't outcome metrics that reward physicians for not knowing. Besides, physicians are used to being praised for having the answers, not for opening up to what they don't know. Physicians aren't trained to deal with the vulnerability incurred with not knowing. There's no subspecialty of like not knowingologist. It doesn't exist. And what about the public? Some patients come to the ER because their patients did indeed have an honest discussion with them about their vague complaints, and they were unhappy with that, and they came to the ER for a diagnosis. Now, I hear all the claims about disruptive technologies transforming medicine, how we'll soon be doing cardiac surgery on ourselves with our iPhones. And I have no doubt that medicine is in active evolution, if not revolution. But I believe a foundation is so core that it can't go away without medicine becoming something different. And it's the role of story. Patients telling stories to physicians, and physicians telling stories back to patients. From the perspective of not knowing, there is a particular dimension of narrative that I want to point out. The cognitive psychologist and narrative expert Jerome Bruner has written how great narrative is an invitation to problem finding, not a lesson in problem solving. It's deeply about plight, about the road rather than the inn to which it leads. I see several applications into my clinical practice. First, at the most basic level, story isn't the vehicle towards a diagnosis, it's the destination. And when a patient's story becomes unwieldy or doesn't point to an obvious solution, it's easy enough to engage with patients at the level of story. I understand you have chest pain, your stomach hurts, your feet tingle, you're weak and tired, you have headaches, your body aches, you have a rash that went away, your stomach is bloated, and your urine smells strange. Okay, take me through your day. What were you doing, and what were you doing exactly at that moment when you decided that it was time to come to the emergency department? Second, narrative is about plight. It's about trouble. Something has gone awry. And isn't that why people are so interested in stories about illness? What's gone awry isn't only our sense of wholeness, it's our identity, our relationship with our bodies, our conception of ourselves, and our relationships with others. The last point about narrative is its ability to beguile. The consistency of information matters for a good story. Our interpretation of a story and our confidence in those beliefs is not whether it's true, but whether it's believable. Physicians are overly confident in their diagnostic abilities, and some of it might not be our fault. The psychology literature shows how our minds are machines that love to jump to conclusions. It will take random data and unconsciously create a coherent story. And our minds won't bother with information it doesn't have. It loves coherence and neglects ambiguity and doubt. This information is of vital importance in medicine because our confidence in our story depends less on our judgment of the data than on the coherence of the story our minds have managed to construct. This reflects both the power of story and the perils. Stories rest on an edge that separates the expected from what happened. Physicians and patients live in that expectation gap. It's not always a space that's predictable and capped by a satisfactory ending. However, it's also a landscape where, through story, the patient can find a voice and experience, and the experience gain legitimacy. Particularly challenging stories in my practice belong to what Arthur Frank described as chaos narratives. If narrative describes a sequence of connected events, the chaos narrative defies that ordering. Troubles run deep. The narrative is marked by, and then this happened, and this happened, and this happened, and then, and then, and then. These narratives are difficult to tell as well as to listen to. They operate on the devastation that results from a complete loss of control. Frank explains how chaos stories are told on the edges of speech. He said, ultimately, chaos is told in the silences that speech cannot penetrate or illuminate. Chaos is the whole in the telling. When dealing with chaos narratives, it's imperative that physicians resist the urge to impose false order or closure, and instead recognize and embrace the complexity. The tough part isn't simplifying what isn't simple, but the willingness to become lost in the complications and to acknowledge that we live with complicated truths. The patient, Cheryl L., told me something came up, and she missed her appointment at the methadone clinic. This absence led to her being kicked out of the methadone clinic for 30 days. Without methadone to quell her cravings, she returned to her heroin habit. The following week, her boyfriend died suddenly. Whether it was related to her drug use or his heart stopped because it was time, though he was only in his 40s, she couldn't or wouldn't say. His death was devastating, and she sought comfort in more heroin. Only he was the one who found her veins. And with him gone, she skin popped, and now purple and blue abscesses marched up her arm. The night before, she'd had enough and overdosed on heroin, or so she hoped. She woke this morning so upset to be alive, she punched a wall and broke a bone in her hand. The lines in her cheeks and jaw were sharp and striking. Someone who's earned the right to be considered beautiful despite appearing jumpy and anxious. Narcotic withdrawal, perhaps, but it could be a separation from or the need for a substance we all depend upon, whether we realize it or not. A little luck, a break, a sliver of hope. When asked if she wanted to kill herself, whether she still possessed a desire to die, she turned away, shaking her head, and after a long pause said, "I'm stuck in a tornado of life." What do we say to someone caught up in the tornado of life, whose problems are so woven with other problems that you're almost afraid to tug at a single thread for the fear of the whole cloth unraveling? So I sat down in awe of her troubles. I didn't try to comfort or soothe her. I didn't have the audacity to do that. I just sat there, and after a long pause, I said, "What's next?" She cried with laughter or laughed through tears. "Look at me," she said, demonstrating the abscesses tracking up her arms. "I can see that," I said. "What next? What happens when you wake up tomorrow? Can you write that line?" Her hands groped through the air, her mouth searching for words. What makes communication and understanding patient stories difficult is that we teach and learn it as text, but so much of medical practice is subtext. Patients don't always share concerns directly. They'll tell stories, expect physicians to probe and pick up their feelings of fear and anger or anxiety. And not knowing gives me traction for exploring the terrain between words and meaning, the literal and the figurative, what's unsaid and what's unsayable in medicine. The playwright and actress Anna Devere Smith once said that we can learn a lot about a person in the very moment that language fails them, in the moment that they have to be more creative than they would have imagined in order to communicate. From a position of not knowing, I'm acutely aware of the vulnerability involved in telling stories, especially in my practice when patients reveal intimate details to a total stranger. Their stories can be tender, fragile constructions that are taking shape to the patient in real time as they are being spoken, and my responsibility is to treat those stories well. This means preserving their narrative as best as I can. I try to listen as a writer. When writing stories, you're moving into what Eudora Welty calls open spaces. You're aware of characters, the choices they have to make, and how the stakes can amplify very quickly. You're also sensitive to the narrative directions not taken, the elements that don't belong or don't make sense, the dialogue that takes you by surprise and makes you examine a character in a new light. And when I'm stuck, I think about character and intention and motivation and backstory and how this person or family came to be here at this moment to tell their story. By thinking this way, I can resist the urge to impose structure, a false ending, or yield a quick judgment. By starting from this position of a blank page, rather than jumping to a likely conclusion and moving backward, I'm less likely to favor elements that support a presumed answer, a habit that can lead me to disregard what might be other critical details and that also deserve my attention. Not knowing gives physicians permission to be human by making a seat for the imagination in medicine, because an imaginative leap is necessary to understand another human being. To understand not only what's going on in their story, but what could be, we strive for footing in the present, the past, and the future, because tomorrow matters. Engaging with patients requires that we meet them where they need us to be. Making that effort is necessary, and it demands a genuine commitment to problem finding, willingness to explore those tender landscapes as opposed to hugging the shore in the safety of ready answers. Not knowing is a creative, generative space that medicine needs to consider if we're serious about engaging with and understanding our patients in a manner that's authentic and meaningful. If we're serious about making physicians comfortable with uncertainty and in turn have more informed conversations with patients and families about uncertainty. From the position of not knowing, we focus on process, become more intimate with our mind at work, especially our response to constraints. And perhaps, ultimately, I hope it will lead to a reimagining of the skills required of future physicians. We must recognize the creative dimensions inherent in medicine, health, and the connection with patients. And this means expanding our traditional notions of healthcare teams and medical education experts to include artists, writers, designers, and humanities scholars. Donald Barthelme said, "Art isn't difficult because it wishes to be difficult, but because it wishes to be art." And it's in this context that I believe medicine is an art, because its central concern is patients, individuals for whom things have gone awry, sometimes terribly so. Life can and will exert its sadistic tendencies, and medicine is capable of incredible things. In the wide eyes of countless patients, there are miracles in our treatments and technologies. I can attest to medicine's promise of possibility as both a physician and as a patient, and that march must continue. But alongside those advances, we can develop skills that allow us to understand the shaky landscapes of our patients' lives. This can be a difficult task, but it has to be difficult because medicine is, at its heart, a human enterprise. The stories patients share with me can be difficult too, overwhelming, ungraspable, and sometimes a source of frustration. But that's why they're here, I remind myself, and that's why I'm here. The point of stories, said physician writer Carlos Williams, is not solutions or resolutions, but a broadening and even a heightening of our struggles. Thank you very much.
This wasn't part of the narrative, was it? Are you okay to take a few questions?
Am I okay?
Yeah.
Sure. Yeah.
Would you like some water? Great stuff. Not knowing, huh? Let's strikes me that the first thing we could do if we really want to celebrate not knowing is to ban negative marking in medical exams. But anyway, not sure how successful that campaign is going to be, but okay, guys, we have about 10 minutes or 8 to 9 minutes for questions. So anyone like to have a crack? Ravi, please.
Jay, I presume you teach medical students or residents. How do you impart those? What's your method of imparting those principles you talked about to trainees, trainee doctors?
Well, we actually incorporate. We have to do a lot of interdisciplinary work with artists, and I think it's one of those. For people who, the artists in the room, and this being Ireland, I think everyone, I assume, is a poet. At least that's what I think. And this type of thinking is not necessarily prescriptive. I think you have to work at it. And so we have done work with artists. We do work with Rhode Island School of Design. We use museum objects as complex bodies of information to get students to become aware of sort of their metacognition and how they think. It's a challenge because it's not like you're spoon feeding them. You know, they have to enter into that space as well. But I find that students, for the most part, find it sort of a very authentic way of thinking about what they're doing, not being told that they have to, this is the way you have to behave in this particular situation, but giving them sort of in the moment tools to sort of be able to respond in their own authentic way.
Okay, thank you. We have another one. Yeah, third row, fire ahead, yeah.
Hi Jay, I'm also an emergency physician, so what you say really resonates, especially about the not knowing. And just to take up, I think it's Ravi that mentioned about education. Do you see a role for improv, so reading that subtext in teaching your residents or teaching that empathy, the space between what's said and what's not said by a patient? Yeah,
and there's actually a growing movement of sort of medical improv. Katie Watson at Northwestern, who is a woman who does of 1,000 talents. But one of them is she is involved with the improv scene in Chicago, involved with Second City, and she and a few others have actually have spearheaded an improvisation movement. And we actually had something. We actually had her out and do some improv actually in our Department of Emergency Medicine just last week. So yes, I think those types of I think once you understand a little bit about improv, and I know probably around 2 hours worth of improv from what she did, is that it seems wild and unwieldy, but there are rules, but there's space for operating within those rules, and I think to have so it's sort of like structured, it's a sort of structured mayhem, but I think that's important. I think the one thing it does is sort of recognize that there are certain things that you just have to be able to respond to spontaneously. But having an idea of where the other person is coming from is also quite beneficial and useful. So that's a long-winded answer to your question of yes, I do think.
Thank you.
I've just had a telepathic message from behind me that one of my favorite bloggers wants to ask a question. Is that correct?
Is that me?
That's you.
Hi, Jay, it's Marie, and that was just wonderful to hear you speak, because actually when I spoke here a few years ago and talked about story from the patient perspective, I actually had you up there on the screen and your quote about the story being the ground that we walk on together. So I'd just love for you just to maybe talk, we hear a lot about co-creation in terms of digital health, and I'm really interested in how we can co-create stories with patients, because one of the things that I'd be wary about is having the patient's story, which can become almost this thing, and then the physician's story. And have you done any work, or is there anybody doing any work about how can we bring those two stories together at that point of intersection? Is there a way that we can co-create a story together?
Marie, you had to come up with a tough question. It's always the last question. It's always tough.
I'll help
so
you.
no, that's a great question. And so I'll come at that question from a few different perspectives, and hopefully one of them will click. Maybe it'll establish some kind of mosaic of sense. So one is this idea of sort of narrative surrender. Arthur Frank, who I referred to in this talk, wrote this amazing book. He wrote several amazing books. One of them called The Wounded Storyteller, and he introduces this term of narrative surrender, which is when patients come to their doctors and tell their stories. You think about it, that whatever the patient then tells the physician or the healthcare, and when I mean physician, I mean nowadays, like it could be nurses, it could be nurse practitioners, it could be mid-levels or whatever, nurses. The physician is basically making decisions about what is relevant information, what's not relevant, like what counts, and that's really sort of important because that's the story that's going to be moved forward, and the literature shows that we're sort of not very good at deciding what's really relevant and picking up on patients' concerns. So this idea of sort of when we think about co-creating, we have to make certain that the story that we're both telling is the same one. Because oftentimes the story that the physician or healthcare provider or the healthcare system is responding to or thinking about is not the one that the patient is actually telling or saying. So being respectful and being mindful of the fact that patients are surrendering their stories to you, and that's a great responsibility to get it right. Like, you might not get everything perfectly right, but it does mean you have to have a sense of like what are the core concerns. When you're writing, like what's the heart of the story? Like what's the heart of what they're trying to say? So I think more transparency about the process. I love the whole idea of open notes, and I'm one of those people who initially, when the idea came out, was like, no, I'm not going to have them listen to what I'm writing. But it also makes you a little bit more responsible of what you put down on paper. And I think the last thing is what we have now, which we didn't have even a couple of years ago, is really just a very empowered patient advocacy movement. And so before, I think the voices that were telling these stories were physicians or the healthcare system. And now, we have bloggers, we have people who have a strong social media presence, and patients themselves are sort of saying, no, listen, this is our experience. So will that get there? When we think about co-creating narratives, is it going to get to that point where they're creating narratives together? Or is it going to be sort of balancing narratives where this is going to be the healthcare system's narrative or the physician's narrative, and this is the patient's narrative, and they're going to be balanced, and there's going to be more of equal partnership in that? Because that's different, because one is sort of partnership and co-creating as, okay, I think about, is it like Lennon McCartney? Is it someone writing the words, someone writing the lyrics? Is it people sort of sitting down and going, okay, we're gonna sit down and actually construct this story and manufacture this experience together? I don't know if that's feasible or not, but I think at the very least we have to raise the level of the patient discourse and honor what they're saying.